Mic on?
We're going to mic up now. Ed is also a board member of ASRA, and he's involved with legislative efforts from the American Society of Anesthesiologists. So, Ed, do you want to give us some takeaways from the first day?
Why don't we start back over? We're going to start back over with our Facebook Live audience.
Perfect.
Hi, everybody.
Hey, everybody. This is Raj Gupta, Gary Schwartz, and Ed Mariano. We're live from San Antonio, Texas, at the ASRA Fall Pain Meeting. We are. This is the first full day at the meeting, and we're just kind of doing a recap of the day. Some of the stuff that we heard today. We're in the exhibit hall. It's getting lively already, and we wanted to share that with you. Carlos Pino is here with us. Carlos, hey, how are you?
All the way from the University of Vermont,
us
practicing pain management there. So we have a lot of experts here at the ASRA Fall Pain Meeting. Any updates that you'd like to talk about today? Highlights that you want to discuss from the meeting so far?
No, very. Thank you. It's been great. We had a great cadaver workshop early this morning. Moderated some posters. They were all very top-notch presenters.
Any specific poster that stuck out, or you thought that was particularly interesting?
There were some on neuromodulation for chronic abdominal pain that were very enlightening, very good. There are some, old favorites about mexilitine. I haven't used mexilitine in years, but there was a poster on mexilitine.
In what situation was the mexilitine coming up?
It was actually neuropathic pain. They were talking about neuropathic pain and patients that actually they tried them on lidocaine infusions before. In those responders, then went on to try mexilitine. So very interesting.
What's old to do again?
That's right. Well, ketamine came back, right?
I had a colleague that worked in the military, and he would work with amputee patients, and they would give gabapentin, mexilitine, sometimes some ketamine, and NSAIDs and stuff for amputees. And they saw an appreciable difference in chronic neuropathic pain, some phantom limb pain reduction. And I know he was intermittently using mexilitine in the hospital with some of our amputee patients. So it's interesting that people are starting to explore it again.
I thought it was very, very interesting.
Speaking of neuromodulation, Elson Sylveston, is that how you say his last name? Elon, sorry. Yeah. I always pronounce his name wrong. Got a $200,000 grant from the ASRA Society to conduct his research on neuromodulation and cancer pain regarding chemotherapy and neuropathic pain. So we're looking forward to his research with the money that he got his grant on over the next couple of years. There's a lot of big advancements in neuromodulation, spinal cord stimulation coming out of the pain world. So we're looking forward to how that's going to hopefully help patients, decrease the amount of opiate use, and just give people their quality of life back.
We had a great session. So I participated in a session this morning on just trying to advocate for the specialty, and so it was a kind of interesting mix. I mean, I talked about what I often talk about these days, which is using social media to build community and to try to advertise. Exactly. So this is a good example. They try to build community, try to promote truth in pain medicine. And so I try to focus really on what's interesting. There's some literature out there now just showing the growth and the perpetuation of fiction with regard to information, especially I gave the example of in the pain management space. There are so many things that are out there that may start out as kernels of truth or maybe even untruths in terms of therapy, and then they slowly grow and grow and grow, and it propagates over time. And if you compare that to the growth and the timeline for dissemination of actual scientific information, it initially explodes, and so new scientific information comes out. There's a lot of buzz at first, but then it dies out. And so when you think about the propagation of fictional information, so misinformation related to pain management, it really tells me that pain physicians, pain scientists really have to continue to be actively involved in social media in order to continue to promote good science and good evidence-based care for their patients. If we don't, then a lot of these untruths get propagated, and that's not good for anybody.
No, I totally agree. I think that's
a question for you about that, because that's a problem for all kinds of medicine, not just pain medicine. Sure. Whether it's about vaccinations or about like the flu vaccine or things like that. Nabil's trying to get in here, but he's still hanging out in the corner. But the question is it the platform that we're not engaging in because that's where people are, or is it the fact of how we deliver the message, right? Is the content that's presented in on the fictional material packaged in such a way that it taps into people's emotions and is already confirming biases that people have, and so that's why it propagates. And how do we, as scientists, propagate good information so that it is packaged in a way that people are ready to receive it and share it?
I think it's a complicated answer. I mean, I think that everything you mentioned is true. So I think that we do have scientists working in basic science, translational research, and clinical science, trying to find therapies, find answers for not just mechanisms of pain across the spectrum, but also safe interventions for patients, especially right now in light of the opioid epidemic. That's all true. I do think that one of the things that we could probably do better is not just to engage patients, engage real people, the general public, where they are, so on the internet, on social media networks, but also to take some of our good science and translate it for them. Much of what we publish in journals never gets read by anyone except the handling editor and maybe the reviewers. Right. And I say maybe. Unfortunately, that doesn't get digested by the general public, and so I think that if we are doing great research that should impact the way that patients get care, then I think that it's really up to us to try to find the tools, if we don't have them ourselves, to get those scientific discoveries worded in a way that the layperson can understand.
Do you think there's an opportunity here for ASRA, or as a group of social media interested folks in ASRA, to maybe take certain topics and summarize them and just, lay them out there in social media?
So that's a very loaded question, Carlos, because we're already doing that. So.
Well, but we're doing this as individuals, right? And that is very time consuming.
So for those that are interested, so ASRA has actually commissioned a public relations committee that Ed and I are kind of part of, that we're trying to figure out how to do that effectively, right? How do we take that message, repackage it, and so far, when we're on this platform, when we're on Twitter, when we're doing journal clubs, we're talking to ourselves. We're talking to our own community, right? And so we can pat ourselves on the back that this new science is there and it's changing practice, and that may be true. But our message is not set up to be delivered to a public audience. Okay, those falsehoods, those myths that get propagated, those are specifically packaged for public audience. So what we're trying to do is, how do we translate good science into a format that the public wants to hear, is ready to hear, and can understand in a way that's meaningful and affect change in their perception. So we're currently in the process of creating those messages, figuring out what the delivery vehicle will be and who the messengers will be in the ASRA community. So that's happening right now, and hopefully you're going to see experts in ASRA speaking out to journalists, to television audiences, to radio audiences, and everything else. And we're hoping that this all gets the message across bigger. Come here, Jamie Barada is here too. Jamie,
hey, come on in. There you go. Oh, you're live.
I believe Jamie will be chairing the 2020 meeting in Las Vegas.
No, San Francisco.
San Francisco, close. Raj is chairing in Las Vegas.
Raj is chairing our spring meeting.
I think also about social media that's important now. There's a big hashtag Verify Healthcare campaign going on in social media, so the right people are displaying the correct messages and getting rid of these myths to the lay people in public. And also the American Board of Anesthesiology joined with some of the other medical boards to display Certification Matters, so you could find out which practitioners are board certified in their specialty, so you know what they're doing. Any updates on your upcoming meeting, Jamie?
Well, I'm really working on the meat of it, and always looking at anyone that's interested in becoming involved and things like that. So, but first, I want to promote Raj's meeting, definitely in Las Vegas. So get that content in. As far as abstracts, case reports, get those applications in by January 7th.
January 7th is the due date, so if any of you are watching on Instagram or Facebook, you could still apply at ASRA.com.
We already turned one in.
Do you have a theme for your meeting in mind?
It's more kind of a perioperative, where are we going in anesthesia and acute pain, and really our role more in a perioperative realm and moving beyond the ORs is really what a lot of our focus will be.
That's good.
We have all 3 upcoming spring meeting chairs all in one place. Yeah. It was great. Yeah, we were just talking about some of the sessions that we were in today, and so a lot of times, I mean, we're sort of all mutually exclusive because like when you're teaching something else and I'm teaching something else, and so one of the things that I think we all have leveraged our use of Twitter for is really just to learn from each other because we're all in different places. But yeah, I think that in my session what was interesting was I was paired up, so I gave a talk on social media, but it was really an advocacy session. And so we had Jay Greeter from Kentucky. He gave a really interesting talk about negotiating with payers, which that was fascinating. He did a really nice job, and I mean there were a lot of great take homes. But one of the things that he had mentioned was that sort of this trend towards these huge mergers between insurance companies and pharmacies, insurance companies and other insurance companies. They're making it much more difficult for the practitioner to negotiate because they really control. They hold all the cards, so to speak. They're bigger. Yeah.
I think one of the big takeaways from his talk was that the physician has to be prepared in their negotiations. You have to have a walk-away number or point where you're willing to say, no, we will not accept this. You have to bring data to these meetings so you're prepared to defend what you feel like you deserve. And also you can't get angry. You have to go there with a cool head. You have to be calm. You can't be like, I'm just a physician and pay me this and slam your hand on the table, because that's going to go nowhere. You kind of have to be a partner with them, bring your data, stay calm, and try to explain your point of why you deserve what you deserve.
So I want to say, while we're watching, I was looking through the comments. So Eric and Jenny are watching right now. Usually they're standing on this side, so they can't be with us. Eric's shoveling snow in his driveway right now. And,
so it's a great thing to touch snow. That's a great feeling.
I told him it's a chilly 55 over here.
Tell him not to hurt his drumming hands.
Right. Don't hurt their drumming hands, Eric. And then Jenny was asking, what was the most surprising thing that we've heard so far at this meeting? Anything surprising? By the way, we've got somebody in Thailand listening to us right now, somebody in Ann Arbor. So we got several people from all over. If you guys are listening from somewhere else, send a comment and let us know where you're listening from.
I think Rick Tucker, the former DEA agent, that in 2009, the most stolen item in the United States was flat-screen TVs, and I think Raj knows the answer of what's the most stolen item now.
Yeah, it's controlled substances. So since 2009, the most stolen item off those big 18-wheelers is controlled substances. We have a society where that demand is higher than what we usually think of as being stolen, high-priced, high-valued items. That was a real shocker to me. I mean, listening to his stories about the kinds of people that are selling pills and drugs, the people that you would walk down the street, assistant principals of schools, a pastor in a church. He said in any city, in any town, he knows how to go find somebody to sell him pills. That's how pervasive this problem is.
I think the other shocking point that he brought up was only 30% of patients or people reported getting controlled substance from a physician. 53% got it from a relative or a friend, which is an outstanding number considering there's a couple 100 million pills out there in the United States, so 53% are getting them from a friend or relative. That was shocking to me.
It's a good time to stop and recommend people about opioid disposal events or locations in your area. If you've got leftover opioids, there's places in almost every state, even a police department or certain fire stations, certain pharmacies will take it. And then I know in our state, they'll have events periodically to promote opioid disposal, safe places to get rid of old opioids that you were prescribed that you don't need. Don't leave them in your house. Don't leave them in your closet. It could get stolen by a family member, somebody visiting your house, or you may be tempted to relapse and just get it out of your.
Yeah, we just posted new patient education materials on the ASRA website, just under patient information. We worked on this for several months. Gary was involved in this. We also had Floria Che. We had Dr. Chad Brummett from Michigan, who's worked on opioid safety and opioid take-back programs in his state. And we put together a safe opioid storage, safe opioid tapering and disposal handout that anyone can access publicly. It's not behind a firewall, and so hopefully that can help people, because one of the things that we did a project recently at our hospital just searching online for educational materials available to patients related to safe opioids, safe opioid management after surgery, and it's really unfortunate. We've seen a rise in public information related to storing opioids, like keeping them in lock boxes and whatnot, and we've also seen an uptick in the available information on disposal, but there's very little information on tapering. And I don't know how much that has to do with the importance of individually tapering people versus just the issue of not wanting to commit. But the problem is, like, there are no tools out there for patients and for practitioners to use to guide patients. Because we've all had these stories where we either have had a patient or know somebody, like a friend or family member, who got prescribed 80 oxycodone after a surgery, and it says take as needed every 4 to 6 hours, and they say, well, I want to be a good patient, so they just take it.
Yes.
And then all of a sudden they stop taking 80 tabs, and then they go in the withdrawal.
Right. Right.
And I think that those are real, and these are educated people. Like, I can think of someone just offhand that that had shared that story with me, and I just thought, wow, that's really interesting. But I mean, those are out there. Yeah. Actually, one of the guys on my panel, his name is Dr. Larry Driver, and he's a Texas pain physician. He had just had his hip replaced this week, and then he came and had his surgery, and he said, well, I took 1 oxycodone after surgery, and then they still sent me home with 80.
Wow. He had 80 pills that he didn't use, and he was like, why are you guys giving me this? He's like, maybe they're giving me special treatment because I'm a physician. He's like, I didn't know what to do with it. I have all these extra pills. I have to return them. And he's an educated pain physician.
So a lot of networks, hospitals, the VA is doing something like this. States are limiting the number of pills you can give after surgery now, depending on the type of surgery. That's a very sticky point with a lot of people. How do you guys feel about that?
I think that this is where I think it's very complicated, as you know, because I think it is such a public issue that in many ways states and also federal agencies have jumped on the idea of legislating or regulating medicine, and I can at least say that I don't agree with that. I think that a lot of the arbitrary time limits or arbitrary pill numbers, they're not based in science. I think that we need to try to develop that and provide the science. But until we have those things, because of the public pressure, they're going to keep coming down the road, right? So the best thing we can do is what we've tried, like within our own institution, is we set up a program starting in May where all of our patients who have joint replacement are managed on an inpatient basis by our acute pain service, who are all anesthesiologists. And so within a day after surgery, they're all off IV pain meds and they're all on oral pain meds. So for the 24 hours before discharge, we can count their number of tablets that they've consumed on an as-needed basis, and we can use that as their max per day. And then we've set up a tapering schedule for them, so it's individualized based on the patient's 24-hour use before discharge. And then we created a grid so that way our orthopedic staff, when they discharge a patient, it says specifically what the label on their pill bottle will say. X number of tabs for this many days, and then X number of tabs max for this many days, and then you decrease it every 2 to 3 days until you're off. And with the target being everyone's off in 2 weeks by the time they have their 2-week visit.
That sounds like an optimal plan. I think that gets back to Ed's original point, is that we have all these arbitrary numbers, being some states 3 days, some states 7 days, 10. But I think we have to bring it back to the physician-patient relationship, that maybe one patient needs it for 10 days, one patient needs it for 6, and Ed might need 1 pill, I might need 3 per day. We have to individualize it to each patient so they're comfortable, and the biggest thing is to get them moving and get them off within a certain amount of time so it doesn't become a chronic issue.
So I want to share a story. One of the commenters was putting on here, I hope she doesn't mind me sharing it on here. So it's Joan from Minnesota. She said she lost her son to the opioid epidemic. She said, on the other hand, she has a rare nerve disorder, pudendal neuralgia, but her son died because of her drugs. And so she said back in 2001, she didn't know that these opioids should be locked up. And she said her family ultimately paid the price for just the lack of awareness. And unfortunately, Joan, I think that there's still so many parts of this country that are unaware of that risk. I really appreciate you sharing your story. I know that's hard to put out there publicly, but I hope that helps people realize that, these bottles just sitting in your closet are not routinely safe. That we don't know who's going to get their hands on them, and in addition, the less that we can give people on the front end, the better off and the less likely that's going to happen. And so, she said she had, within 6 months of her accident in 2001, she had multiple bottles of opioids, boxes of fentanyl patches, and just had so much. And she said she's worked a lot on reducing her opioids now. She actually is one of the people using medical cannabis to help her with the tapering of opioids. So it's a devastating story, but unfortunately it's happening in so many families. Again, thank you, Joan, for sharing that story.
A complex issue in tapering too is that tapering opioids after an acute event or after surgery is very different than tapering after long-term use. And long-term use, for individual patients, has to be done very, very carefully, and it has to be individual. Right? Because I think that you have to work with your pain physician. You have to make sure that first that you're still practicing good pain medicine. And I think that we all know. I mean, you get beat every single day. We're beat over the head about how opioids aren't indicated for this and opioids aren't indicated for that. And I think that what we can't forget is that there's a patient that needs care. And we need to make sure that the patients are getting the right care. So I think that they also know that because they're hearing the same information that we're hearing. Yeah. But I think that there is definitely an anxiety in the public about the opioid crisis and what it could mean for them, because up until now, maybe there haven't been great alternatives for them, or they haven't been regularly available or haven't been offered. And I think that we need to start pushing that message too, which is to say, look, it's not just about taking away your opioids, it's about treating your pain in a way that hopefully treats it better. With more, maybe less reliance on sole therapy, and maybe more of a multi-pronged approach.
And I think that's a great approach, putting it back on the physician's responsibility, because the truth is that I've had to be in front of the legislature, and they often tell me, it goes like, well, you guys are not doing enough. We have our constituents and they're asking us to do things, and I think that's where they come down to, limiting by rule or law the amount of pills that we can get. So I applaud your initiative. I think that's a great initiative you guys are doing. I think we should definitely do more.
I think we've also been working with the pain psychiatrists to actually bring patients in that have been motivated to wean and help, like using a multimodal approach using ketamine, and we've been able to wean several patients completely off opioids or to much, much lower doses, and to have even better pain relief. And I think that is even getting that to patients, that these options are out there, that we can do things to help them, and working with the pain psychiatrists can be very beneficial to patients.
Introduce yourself.
So I'm Magid Gurgis. I practice at Ocean Health System in Louisiana, and I do anesthesia-based chronic pain. Been doing that for about 6 years now.
So what do you think what was interesting today that really struck out to you from the meeting?
So I think overall it's a great meeting. I mean, I've seen like the design of the workshop, and I would say some of those new blocks. I mean, I'm very glad Dr. Kasbani was able to share with us was really good. Also, a couple of the main meeting presentations were excellent. And strikes me good is that we're promoting a lot about diversity in ASRA, and that's something that really touch a dear portion of what I like to promote, and I'm happy that is being taken part of the meeting.
I guess sent his first tweet today.
So actually, that's awesome. So mentioning diversity in ASRA and how ASRA is taking care of diversity, me and Dr. Mariano just came back from one of the SIG meetings, the special interest groups, and it was about women in regional anesthesia and pain medicine. Fantastic group, phenomenal ideas, a lot of enthusiasm, and essentially this is a testament how this society is trying to promote women, minority, and how we essentially, there is a fundamental belief that with diversity we are stronger. Everybody can bring something to the table, okay, irrespective of who you are or where did you come from. And this is essentially something is not as they say, just a window dressing to just make everybody looks good. I feel this is something really going into the fabric of this society.
I think another big topic of the meeting that's come out interesting is physician wellness and physician burnout at the meeting. Andrea Nickel, who I believe is chairing the fall meeting next year in New Orleans, had a great presentation about physician wellness, happiness. It's not all about money, it's just life experience that can make you happier, and we can transition that to our patients, because the better that we don't get burned out, we can provide better care to our patients. I know Philip Pang from the University of Toronto is actually hosting a Tai Chi exercise with physicians, which I personally recommend for a lot of my elderly patients, especially with chronic osteoarthritis, because we want to get them to move, and they're not going to be running a marathon per se, but even like 20 minutes per day of doing Tai Chi could help keep their joints loose, decrease their pain. So ASRA's been doing a great job of that, promoting it for their physicians and to the patients. I think that's very important.
And also, I'm gonna put a blog in for one of the things that we're trying to do about networking. So this year is gonna be the first year, or this meeting is gonna be the first meeting that essentially there is something called Let's Eat. All right, and Let's Eat is essentially you sign up and you go out for dinner with people, essentially random people that you did not know before or may have known before. But it's a great way really to create that sense of community among ASRA members, and it's really great. It's fun to come and meet friends and just catch up with everything. But also it's a lot more fun to really get to new people and learn about what they do and who they are and where did they come from.
I think it's a great idea. I mean, I think that part of being at this particular venue, this resort, is that there isn't really a whole lot around here. I mean, I think I heard from Gary that there's a Target within driving distance, but that's pretty much it. And so all of us are sort of taking advantage of the fact that it's like being at pain medicine camp.
This was all planned by Max, by the way.
A nice way to say that you're trapped.
Yes, so in a good way. So then it's more of it's a networking camp. So so we're all seeing each other everywhere in all the common spaces, and we have these Let's Eat events. We have a networking session tonight, and then we of course have like our tradition, our Saturday event, the Cowboy Cookout at the end of the meeting.
It's also the first time they have a mentoring session between people who have been to the meeting before and first-time attendees. So they have assigned 10 to 20 people with mentors. If they want to reach out, they can call them, meet throughout the meeting, which sessions they find interesting, meet them to some of the leaders of ASRA that you see over here to ask them how they got involved, what they like about the society. So I think that's different than most other medical meetings, that they're pairing someone who's either been in the society for a long time or been to a lot of meetings to let them experience it, ask questions, meet some of the so-called higher-ups and experts in the field, which I think is a great learning opportunity.
I really liked how Max opened up his initial speech about just addressing physician wellness right off the bat. I mean, I just thought that was a really nice way to open the meeting and kind of bring to the forefront the importance, I think, of enjoying your career. And so he had sent a message to all of us who were moderating or speaking that we would try to share something we learned or something that we believe in that's kept us excited about working, because the average physician career is 31 to 36 years.
Right.
So how do you keep it going? You know what I'm saying? So I thought that was interesting. Did any of you do that at your in your sessions? Did any of you share something that you believe in?
No, I did not.
That keeps you going?
That's something that.
Do you know what keeps me going? I'll tell you now. Keeps me going is everything I do helps me meet new people, right? New smart people that I like to talk to, that I like to hang out with, and that keeps me wanting to do more, because if I stop, then they have no reason to talk to me anymore. So meeting new people, hanging out with them, learning from them, and engaging, I think that keeps me going. Yeah. So I want to wrap up. We're going to wrap up today. We're going to come back tomorrow. We're going to do Facebook Live again from the exhibit hall tomorrow evening. But for today, I want to wrap up, say thank you for joining us. The video is going to be on Facebook afterwards on the ASRA page. We'll send out some tweets on the Twitter account as well. But a couple things. Follow us on hashtag ASRAFall18 So you can see all the activity on Twitter going on during the meeting, and then the spring meeting's coming up. That's going to be in Las Vegas. That's right.
And
around
guess
the
who's
corner.
chairing that meeting?
I don't know who's chairing that.
I know who's chairing that meeting.
I'm not sure
I know
yet.
the one and only,
don't think they told
Dr.
me yet.
Gupta. Yes.
So, important thing about the spring meeting, more than anything else, abstract submissions are open right now until January 7th, and their submissions are coming in like crazy. They said that the submissions are coming in faster than any other meeting we've had, except for the World Congress, I think, which was an exceptional meeting by itself. So get your abstracts in, get them done, don't procrastinate. January 7th, seems like a long way away, but go ahead and get it done so you don't have to worry about it over the holidays. So go to ASRA.com, check out all the details about the spring meeting. That's right around the corner. Wow. Oh, Philip, hey! Philip Payne.
Yeah.
Say hi to Facebook Live.
Just say hi.
Say hi to the camera,
Say,
Philip.
have a good night, and we'll see you tomorrow.
Philip's going to be teaching us Tai Chi on Saturday, so
That's right.
I speak Spanish. Hola, ¿cómo está?
If you give them save the
Perfect.
date for the ASRA fall meeting in 19, that's going to be in New Orleans.
New Orleans.
I'm expecting to see everybody in
That's
New
what
Orleans.
New Orleans was fun for the spring meet. The spring meeting we had a couple years back, 2 years back. That was a great time.
And guess who's the chair for the fall
I don't know
19?
who's the chair for that meeting.
For Andrew Nicole.
Oh yeah, Andrew. And then what about the chair for the next meeting in the spring? Oh wait, that's Jamie.
Hello, Dr.
Wait.
Murata.
How do we know all these people?
I know.
All right. Thank you guys for joining us. See us again tomorrow.
See you guys.
All right, bye guys.
Bye.